Good morning and good afternoon, good evening, and thank you all for joining us today. I'm Wafa El-Sadr, and I'm the director of ICAP at Columbia University. And I want to welcome you today to this very important ICAP Grand Rounds entitled The Cost of COVID-19, Understanding the LGBTQ plus Experiences in New York City. We're honored to have been able to conduct this very critical survey over the past several months to get a glimpse as to how this community, this vulnerable community right here in this city have experienced COVID-19 and to understand not only their experiences, but also their needs as well. It gives me great pleasure to introduce Andrea Lowe to present the final, the results of the survey, and also to share with you some of the key findings, but hopefully also to have some conversations at the end in terms of your questions and your queries regarding the findings that she will highlight. Andrea is an assistant professor in the Department of Epidemiology here at the Columbia Mailman School of Public Health, and she's also a key leader in our project that's focused on population-based surveys that we have been conducting in collaboration with Ministries of Health and CDC in various countries around the world regarding the impact of HIV. So I'm going to hand it over to Andrea now to share with you some of the key findings from the survey. Welcome, Andrea.
Thank you, Wafa. Let me just share my screen. Here's the agenda. We've had the welcome and I'll be doing the presentation. We will have a substantial amount of time at the end for questions and discussion. So just a moment. All right, are you seeing the slides?
Yes, looks good, Andrea. Please go ahead.
Perfect. Well, great. Thank you so much again to Wafa and to everyone who's joined today. I'm very pleased to present the results of this exciting survey for the LEXICON team. Excuse me. Great. So to provide a little bit of background about the rationale for this study, it's been really highlighted both in the scientific literature, in the media, and so on, that there has been a real gap in collection of data on sexual and gender minority health during this pandemic. And Sean Cahill and others back in September 2020 highlighted this in the American Journal of Public Health. And this was also reported by many others. And the real concern is that because of a number of different types of vulnerabilities, including economic, secondary to long histories of discrimination and so on, but also health and behavioral vulnerabilities, that there was a real concern that the burden of exposure and severe disease would be much higher in LGBTQ individuals. And aside from these vulnerabilities linked to, higher rates of poverty and so on, we tend to find that there's more of a concentration of LGBTQ people in urban areas. They have a lot of jobs that were deemed essential that are people facing, so in retail and restaurants and so on. And of course that carries with it a risk of exposure. And some behaviors such as higher rates of smoking or vaping, and some comorbidities. So HIV has been linked to more negative outcomes, and so have some other comorbidities, metabolic and so on, that have higher rates within this population. Now, a year later, Sean Cahill also wrote a follow-on saying, despite this call for better data collection, there was still a lot of data missing on the public health impact of the pandemic, and because these data are still not routinely collected. So here we have data from the New York City Department of Health. I downloaded these data yesterday. There's a treasure trove of data there on the pandemic, both in terms of cases and who's really being impacted and where. And we can see we have disaggregation here by poverty and race and borough and so on. We also have, I'm not showing that you have sex and age and a few other disaggregates that you can explore. And then you can also look at mortality rates and so on. So really excellent data, but it isn't disaggregate to present data on sexual and gender minorities. And here are two articles from last spring on from the New York Times highlighting this as well, that despite the fact that, or because of the fact that there's so many intersections of things that generate medical mistrust, there was concern that LGBTQ people would be much less likely to get vaccinated. So to address some of these gaps in data collection, there was a survey done in the fall of 2020. This is by the Williams Institute at UCLA, and they partnered with Axios, who have a nationally representative online probability panel. It's a national survey, and they were able to confirm that LGBTQ people of color had almost double the rate of HIV infection as they saw in non-LGBTQ white people, but LGBT white people didn't have any significant difference from non-LGBT. They also saw that the economic impact was very disproportionate in this group. So people of color within the LGBT community, almost 63% were very concerned about being able to pay bills during the pandemic. And we did actually see there was an impact of being a sexual and gender minority within the white population as well, who still had an almost 10% higher rate of concern than the non-LGBT white population. Now, if we think about vaccination coverage, you can see more of the data from the New York City Department of Health. Now, we have here I'm presenting just one dose of the vaccine because that is analogous to the data that we collected. But as we know, we're now, sort of in the booster era. But you can see that we're actually doing quite well in much of the city in people having more than 90% who've been vaccinated, but there are still areas that are lagging, and that's where Columbia is located, Upper Manhattan. We have some little areas where it's only it's less than 70%. Staten Island lags in some areas, and some areas sort of further away in the boroughs, you also see these patterns of people lagging behind. And if you disaggregate this by race, ethnicity, you can also see that the Black population also remains, there's a critical gap there in terms of accessing the vaccine. So another survey that was done by the Tegan and Sarah Foundation, this was in June of 2021. So after the vaccines have been made eligible to all adults, you can see here, so it was a national survey online, and you can see that it's mainly along the coasts that they had the highest rates of people replying, and these were mainly also urban samples. But already they had 68% who were already vaccinated. That's the dark part of the pie. And then if you look at gender identity, this was even higher amongst cisgender participants, so 72%. And then there were still gaps in coverage for transgender or other gender minorities, where even those people who didn't reply about gender, they had 51% at that stage who were vaccinated. But if you looked at vaccine intention, so as soon as possible would include those people already vaccinated or those people who hadn't yet had a chance but really wanted to get vaccinated. There you actually see that gender minorities had high vaccine intentions. And these are actually higher than some of the other groups within the population. But when you disaggregated by race and ethnicity, you did see, again, some of the patterns that we've actually seen in the broader population. So Black participants, only 70% said that they would get it as soon as possible, compared to as high as 87% in Asian people. But what you do notice is that it's not a vaccine refusal. Here it's vaccine reluctance. So 26% said they wanted to wait. And this has been correlated with concerns about the safety of these vaccines. And it's based on, again, this medical mistrust. Now, interestingly, they looked at those people who had been vaccinated or said they were going to get vaccinated quickly. The vast majority, 94%, said that they wanted to protect their community. whereas 90% said they wanted to protect themselves, 70% said they want to go back to normal activities as quickly as possible, whereas 83% wanted to avoid to get seriously ill. And when they looked at those people who had not been vaccinated, either the ones who were reluctant or the refusers, you could see that primarily they were being driven about concerns about safety. So this encompasses both, side effects and other things. And then you see this question about the development process, whether these were developed too quickly. And certainly if you look at gender minorities, you can see this bad experience with healthcare providers that people have been very worried about within this population, that more than 1 in 3 said that this was a reason why they would not get vaccinated. And if you look, there's an article written by Ishan Garg and others that did a systematic review last year, looking at all the data on this population and vaccine hesitancy. These are the main drivers that you're going to see: safety, side effects, and to some extent bad experiences with healthcare providers. But really safety is key. And this really is very similar to what you see in non-sexual and gender minorities. So we wanted to be able to do something similar a little bit later in the pandemic, but we wanted to focus on New York. We have the largest population of LGBTQ people here, and it's sort of a special case. I think all of us who were here in the spring of 2020 recognize that we were hit early and we were hit incredibly hard. And the sort of emotional impact of those lockdowns and listening to sirens all day and all night, these could have lingering downstream effects. And of course, now we keep having these surges with these variants and so on. And this article from the New York Post, that's actually from just this last week, January 16th of 2022. But it's highlighting that even though, quite remarkably, they're estimated that we will reach pre-pandemic employment across the US by probably the end of this year, and even better. In New York, they anticipate that we will not recover jobs-wise until late 2025. So we have lingering negative economic effects in the city. So thinking about that and consideration of the importance of the community here and so on, we wanted to focus on 2 things. Of course, vaccination is critical to understand what the uptake might be, what the attitudes were around it, what might be some of the barriers to uptake, and what intentions were, but also on the infection burden. So looking at how many people had been impacted by COVID, and also looking at uptake in testing and these non-pharmacological interventions that we used to mitigate the pandemic in the beginning, and should still be using. These are mask wearing, social distancing, washing hands, and so on. And then we really wanted to focus on some of the other effects of the pandemic. So these are economic, physical in other ways in terms of health, mental health, and an array of another potential effects from both the mitigation measures as well as the pandemic itself. So this was also an online survey. We used the Qualtrics platform, and because we wanted it to be a very diverse sample, we translated it into Spanish, French, and Chinese Mandarin. Our target population was adults, so LGBTQ people who lived in New York City and who were aged 18 and older. We used our sampling frame. There are roughly about 750,000 New York residents. This is the largest population in the country, and our target was 1,000. Now, the time period was, we launched at Pride, and we were able to complete the survey towards the end of the year. And because we wanted to make sure that we are reaching people who often don't participate in these types of surveys, so more affluent people with higher levels of education, we ensure that we provided an incentive, and this was an e-gift card. Now, recruitment, we are very lucky to partner with people from the Harlem and Bronx Prevention Centers. They have long been engaged in their communities, and we have a number of studies also looking at LGBTQ people. And so we were able to leverage all of these relationships and these various programs and events to make sure that while they were promoting some of these other projects, they were also promoting Lexicon. And so, for instance, we partnered with Harlem Pride, Destination Tomorrow, the Brooklyn Ghost Project, a number of others. So really tried to ensure that we were reaching people, a diverse sample. We use snowball sampling, so we also asked people to distribute the information on the survey to their peers. We used dating apps at Grindr. We were particularly successful, although unfortunately we really wanted to reach people in some of the less represented centers, such as Staten Island and the Bronx, and we'll see from our final sample that it is quite difficult to get people to participate in these boroughs. As I mentioned, we went to a lot of different events. We also distributed material in bars and social spaces. And I did try to convince some of the younger team members that going to bars was part of their job description. Anyway, there was a lot of work trying to make sure that we reached a wide swath of people. And then we also used Qualtrics. They have a panel of people that they've accumulated. It's actually millions of people globally that they were able to look at our eligibility criteria and reach out to them to participate. Now, I did want to mention, and this is something that I think is really critical for consideration of any online survey moving forward, is the issue with bots and bad actors and data quality. And so anytime we advertise with a QR code on social media, and this even within private groups on Facebook, we would get swarmed by these bots. And so this was with all the Qualtrics platforms, the security platform program, sorry. And with reviewing the literature, what's quite interesting is that there are a number of papers about this. One I think that's particularly relevant is from Griffin and others from 2021, that there might be additional targeting of these bad actors to marginalized populations, in particular LGBTQ people. So we imposed a number of additional steps and a tremendous amount of data cleaning and so on, and validation within the system and so on. Our team did a lot of research on how to ensure data quality, but it is something that I think is really critical for moving forward with what is effectively a very convenient and efficient way of data collection, which is these online surveys. I did want to highlight the work of Nora Howell and others at the Harlem Prevention Center and their work in reaching out to the gender minority community. And you can see here just some of their activities. Working in, here's Transgiving that they were able to attend. You can see here our cards. We had little business cards that had the QR code that they were handing out, but a number of different activities. And I think that's why we were able to recruit a good proportion of our sample within the gender minority community. So I'm very grateful for that. And I was very happy to hear that Nora told me that groups like the Brooklyn Ghost Project really liked the LEXICON project because it was a way for people often who were neglected by these data collection methods, who felt like their voice could be heard. And also the $30 incentive was really important to a lot of people. So data collection management, we tried to not let it get too long, but of course, as everyone knows who's built a questionnaire, it can be difficult to restrain yourself just because there's so many things that you want to understand, but the average time was about 15 minutes. We tried not to collect too many personal identifiers. We did have to get an email for the incentive, and we did use that for data validation in a number of cases. We almost never collected a phone number. They had the option to give us that, but they did not. Very commonly, mainly it was email. We did get a zip code, and that was used in a way to validate their location in terms of where they lived in borough. And IP address, we used that as well for data validation. But you can see here some of our modules. We collected a fair amount of demographic data. Here we had the COVID data that included positive diagnoses, had they been hospitalized, if they'd had to quarantine. We also looked at vaccine uptake and some of the drivers of hesitancy. We collected medical history as well as recent healthcare experiences, including health insurance status, chronic conditions, and barriers to care. We collected also lifetime and recent alcohol and substance use, and then the impact of the COVID pandemic. And as I mentioned, these were things about certainly economic impacts, and that included things like employment and housing. We also looked at things like violence and mental health. And so I am presenting some of the key findings here. I did want to note, we have had a number of discussions with people who, policymakers and so on. The wealth of data that we've collected, there's a lot more that needs to be explored. So certainly reach out to the team with any sort of interest that you might have in some of these questions after the presentation. So this is the interface. You can see here the translated Spanish version. We have the French, but you could do it on your smartphone. I'm sure people are familiar with the Qualtrics platform by now, but pretty easy to do and pretty quick. And so these are some of our results. We were able to recruit 1,038 participants. Most of them were pretty young. So the bulk were 18 to 29, with our median age being 29 years. We did have a range up to 68, but I would say most people were under 40. The geographic distribution, the majority came from Brooklyn or Manhattan. We did do relatively well in terms of the Bronx and Queens, but as I mentioned before, recruiting from Staten Island was very difficult, in part because they don't have a lot of venues there or events that take place there to reach the population within that borough. 56% of participants identified as gay or lesbian, so that was the majority, but it is important to note the distribution of other groups, and 28% identified as bisexual. I want to flag here that we have 2% identified as straight, and these tended to be within the gender minority group. Our sample was diverse, so we were very happy to see this. The majority were people of color, so 49% were non-Hispanic white, 19% were non-Hispanic Black, 24% Hispanic, 5% multi-race or other, including American Indian and Native Alaskan. Now, I will also flag another gap was that we only recruited 3% Asian, despite really trying a number of different ways to reach this community. And it is a tremendously diverse community in terms of language and culture and so on, but they are a little bit underrepresented in our data. And interestingly, 9% reported being born outside of the US. And we didn't ask about immigration status because we didn't want to dissuade people from taking the survey, being worried that this was somehow going to be used by the government. But I think this immigration status can be very critical in terms of accessing healthcare. Now, also, our group was pretty financially diverse. It's almost evenly divided across the 4 quartiles that we have. Our poverty threshold, we defined it as a household income is less than $25,000 per year, but that's not actually the city's definition. But you can see we have these intervals of $25,000 for each group. In terms of the breakdown, the intersection here, sexual orientation and race ethnicity. Again, the biggest group were white, gay, and lesbian, but bisexual, the proportion who are bisexual actually becomes significantly larger in people of color. So Asian, we actually have more people who identified as bisexual than gay or lesbian. It increased here in our Black participants, as well as in the other group. But if you look at gender identity, we had 63% who identified as cisgender, and then 37% who are gender minority, including 17% who are transgender. And if you look here at income distribution mapped out, the proportion who were low income was 35% in Brooklyn, and Staten Island was second to that, 26%. And if we look at college education, we find that 54% of people in Staten Island who replied to our survey who did not have a college degree. Finally, I think I'm always shocked by these sorts of data, but 22%, so almost 1 in 4 had been unhoused at some point in their lives. So again, a reflection of pretty serious economic vulnerability. So in terms of some of our COVID outcomes, we can see how many people have been tested. Almost 4 out of 5, 79% had been tested at least once for SARS-CoV-2. We can see here how that's distributed. Sorry, the legend needs to be updated, but most people, 83%, had been tested in Queens, and the lowest proportion was in Staten Island. That's only 64% had even been tested for COVID. Of everyone tested, 31% tested positive. And again, you can see here, the highest proportion were in Manhattan at 40%, but second to that was Staten Island. So they had fewer people tested, but 34% of those tested positive. And you can see that more than half had had to quarantine due to a documented exposure to COVID-19, and almost half knew someone who had died due to the pandemic. And this was most commonly reported by gender minorities and Hispanic participants. The knowledge and practices were actually quite good. Most people, knew that asymptomatic people could transmit COVID. They knew that vaccines prevented severe illness, but they knew also that people needed to continue to follow NPIs. And finally, most knew that if you had recovered, you could be reinfected. But this was actually, I think, the lowest proportion who answered that correctly. And one thing that was really interesting about our data, and I have seen this in some other papers as well, that rather than some of the barriers that people had identified at the beginning within the LGBTQ community, what we found was that the HIV epidemic had in fact led to more people getting vaccinated, being very conscientious about NPIs before the vaccines were available and afterwards, and that this was actually highest in men who have sex with men who are assigned male at birth, where 77% reported that. Non-Hispanic Black participants were 75% reported that, and then gender minorities were 75% reported that as well. And we can see that, I think, reflected in here, where we look at some of these NPIs, where only 9% said that they'd never or rarely worn a mask. That was in the last 3 months. So this took place last fall, actually before the Omicron surge. But 18% claimed that they'd never or rarely socially distanced. In terms of vaccine uptake, 81% had received at least one dose of COVID-19 vaccine. So we are very happy to see that this was pretty similar to what we were seeing in the city writ large. Interestingly, the highest proportion was in Queens and then Manhattan, and the lowest proportion was Staten Island, so 72%. There's no difference by gender identity, but we did see in terms of race, ethnicity, that very similarly to what we see in the city data, rates are lowest in the Black population and really high in the Asian population, where 97% had been vaccinated. Other determinants or correlates of being vaccinated, we found that those people who had a yearly income less than $25,000 were less likely to be vaccinated. Also participants without a college degree. And then very interestingly, the rates of vaccination uptake or having at least one dose was really low in divorced and separated participants, where only 59% were vaccinated. And so the numbers were relatively small, so it'll be difficult to do any further analyses within this group, but I'd really welcome any other comments or people who might understand this finding a little bit more. When we looked at those people who'd either been vaccinated or intended to, so they just hadn't had the time or hadn't been able to navigate the system, and this was the bulk of our participants, 75% said that they wanted to be protected from COVID-19, whereas 46% wanted to get back to a normal life. And this was a select all that apply question. I did find this a little bit funny that only 30% wanted to protect other people. So I don't know if that's a reflection of just a different timing compared to the Tegan and Sarah Foundation, where it was 94%, or if this is more of a reflection of New Yorkers, perhaps. But anyway, it is still something that people select and thinking about their family and household. I found this interesting as well. This was a time of some mandates by schools and employers. So only 8% said that this was a requirement for them. And then interestingly, 0% seemed to be worried about their risk while commuting on public transportation. For this relatively small group who actually said they would not get vaccinated, again, very similar to what we saw with the Tegan and Sarah Foundation data and other data as well. They don't think it's safe. They're worried about long-term side effects as well as short-term. And we also do see that some are worried about the efficacy of the vaccine. Although it wasn't as commonly reported, we do see 16% who are concerned about how fast the vaccine was developed. And I think this is a real area that we can improve as policymakers and so on, which is that a lot of people don't understand that the mRNA vaccines, although they seem to have appeared from nowhere during this pandemic, and then these vaccines were very rapidly made and introduced into clinical trials, I know just from speaking to family and friends and others that even if they do get vaccinated, they're still scared about this. And if you go, it's only if you go to the CDC website that you see that these types of vaccines have been in clinical trials for cancer therapies or other types of viruses now for decades. So their safety overall has been established. But it's just that it was for this virus that we suddenly became aware of. So I do think this is an area that we can improve upon. Now, finally, this, there's so many different minority identities within this group, and we wanted to understand how they intersect. So we did both a univariable and multivariable logistic regression, so we can adjust both for a borough and race and sexual orientation. Gender minority status was not associated with not being vaccinated, so we didn't include that in the multivariable analysis, but you can see here what the key drivers are, and they are socioeconomic. When you adjust for socioeconomics, race, ethnicity is no longer significantly predictor of not being vaccinated, nor is borough, including in Staten Island. But not having health insurance is the key driver, a threefold increase in the odds of not being vaccinated. And you see that as well with household income and education, as well as what I found very interesting, bisexual participants, even after you adjust for all these other things, still had more than twofold odds of not being vaccinated. So when you think about the worry about side effects and safety, and then you have this group who are not vaccinated being one of the remaining groups, still not being vaccinated. To me, I think what's quite feasible is that people are so concerned about side effects. So even if they do know that the vaccines are free, and other studies do suggest that there are many people who still don't know that, the concern is that if you have side effects, you still will have to access healthcare. And if you don't have insurance, that could be debilitating financially. So I think there is a lot of messaging that go around this, and also in accessing these other groups. One other thing I felt like we should note is that I'll present the data on people who actually felt discriminated against due to their race or ethnicity or due to their sexual or gender identity in a couple of slides, but we did not find any association between an experience of discrimination, accessing COVID services, and not being vaccinated. Finally, just the bisexual group, this also warrants further discussion, but there certainly is a lot of biphobia that persists, and it is feasible that this group is just not being reached. The community may not be as strong, and they may not have the same access to resources and understanding about all these different types of services that are available to the LGBTQ community. So another important thing to further explore. Now, we talked about vaccination and the actual burden of infection, but where we're really seeing the severe downstream effects on this community is in the financial impact, where 81% said that they had a negative impact from the pandemic. Overall, 65% had a more negative general impact on their lives. But you can see here high rates of job loss, 36%, 19% of a group with a history of being unhoused were threatened with eviction. And then these really high rates of household violence, 32% with history of verbal violence and 15% with physical violence during the pandemic. And this was exacerbated in gender minorities. So more job loss, 45% versus 32% among cisgender participants, more moderate or severe financial hardship within gender minorities, so that's 59%, 1 in 4 had been threatened with eviction, and 21% had suffered physical violence within their households. We also see more employment loss within racial and ethnic minorities, 24% Hispanic, 21% of non-Hispanic Black people, and 33% of other race ethnic groups have lost their jobs because of the pandemic, compared to only 14% of non-Hispanic white and 9% of Asian participants. And although we don't go into it here, we did also see that physical violence was more common amongst Black and Hispanic participants. In terms of access to healthcare, 23% did not have health insurance. 27% felt that they had been discriminated against due to their sexual or gender identity, specifically when accessing COVID services. And this was higher in gender minorities, where it was 1 in 3. 17% felt discriminated against based on their race. And this again was higher in non-Hispanic Black people, where 32% reported the discrimination. 67% felt that the pandemic did not impact their access to STI or HIV testing services, but many did feel like it had had a negative impact. And here we see that 44% of men who have sex with men who'd had casual sexual partners in the past 3 months had not had any STI or HIV screening in the past 6 months. 17% had not had it in the past year. Finally, although it was a relatively small group in our survey, people living with HIV, 30% did report that they'd had difficulty in accessing treatment for their HIV. Here, in terms of mental health impact, consistent with other surveys where we asked about a lifetime diagnosis, 1 in 4 had been diagnosed with clinical depression, 28% had been diagnosed with anxiety. But if we looked at symptoms over the past 2 weeks, and for those who aren't familiar, the patient health questionnaire, 2 screening tools, 2 questions that ask about recent symptoms, and it is quite sensitive and relatively specific for likely ongoing depressive disorder. Normally, clinically, once you screen positive for this, you have to go through a number of other questionnaires and so on to get a positive diagnosis. So just take that into consideration when you look at these numbers. But as I mentioned, it is fairly specific. And we had more than half who had ongoing depression. Highest in Hispanic people, gender minorities, and pansexual, queer, or questioning people, where 69% reported potential ongoing depression. We also saw 57% who had generalized potential generalized anxiety disorder, with significant overlap here between depression overlap, where 81% who had potential ongoing depression had also anxiety. And then we saw 36% of participants who reported excessive drinking, at least daily or weekly. Now, one of the most important drivers of these depressive symptoms was, in fact, income. And if you look here at some of the lower income, it's very similar at a household income less than $50,000 per year, both for anxiety as well for depression. And then as you increase in income, you actually see almost like a dose effect where you have the steady decline in symptoms. And I did want to highlight that we have another survey, an ongoing survey of an older population, the Silver Project, which is being led by Dr. Abigail Greenleaf, where we actually found that 23% of people over 70 with an income less than $25,000 were positive for depressive symptoms and 21 for anxiety symptoms. And these were the highest proportions. So contrast that to 60% and more in this population. And it's a real area of concern. That we are not addressing the mental health impact within the LGBTQ community adequately. So in conclusion, what to pull from these data? As I mentioned, there's a number of different things that should continue to be explored, and we're really happy to work with others to use these data effectively. But I think it is critical that these data support how badly impacted sexual and gender minorities have been impacted economically by the pandemic, particularly among gender minorities. We, very happily, we do see comparable rates of vaccination, but we do see similar gaps in coverage. And unlike some other studies, we're really finding that the main drivers are socioeconomic, aside from a bisexual sexual identity, which I think, as I mentioned, is important to explore further and understand what the barriers are there. The health insurance, which is this driver of lack of vaccination, we have a lot of participants who are not insured. And then we did find this high rate of discrimination for COVID services in particular. And then the mental health impact. And as we saw on the other slide, there are also these high rates of violence were associated within this group. And we saw that particularly in gender minorities and Hispanic participants. So things that I think we really need to work on. So in acknowledgement, we have an excellent lexicon team. Tom Carpino, Connor Wright, and Joey Platt are really the originators of the sort of rationale for this. Years ago, they became very interested in questions around this community. I wanted to highlight our excellent data team, Christiana Chang, Emily Romero, Rachel Bray, as I mentioned, with all these different issues around data quality and so on. It was building the ship as we went to ensure that our data were validated in multiple different ways, and we were assuring quality. We had the pleasure of working Johanna Gerstein and Jessica Zhang, the students, and I really want to flag Darian Thomas and Nora Howell, who did a beautiful job with working with community organizations and our Bronx and Harlem Prevention Center staff in terms of mobilization for the survey. Always a delight working with WAFA as a key advisor on the project, as well as others in our advisory group. And then finally, I really wanted to thank the Rockefeller Foundation for funding this project. It has been a real pleasure working with them. So now I just want to thank everyone for joining this, and we have time for discussion or any questions that people might have.
Great. Thank you so much, Andrea. I think I will help out here with moderating our discussion. And I know we have at least one or two questions that have come in. So there was one question that came in asking about why do you think medical insurance status was associated with vaccine hesitancy, given that vaccines here are available free of cost? Any thoughts on that?
I mean, it's an excellent question. So one is about whether people aren't fully certain of that. And the Tegan and Sarah Foundation survey, and then some others, not just within the LGBTQ community, have actually found that there is still a gap in knowledge about the fact that these vaccines are free. And so this seems to be particularly predominant amongst young people, but you can understand that there might be communities where the information isn't as readily available, that vaccines come completely free of charge. I think I mentioned this earlier, but I am concerned that people also are worried about potential side effects and the fact that they will not be able to access care if they have them. And I know health insurance is also often linked to employment. So we should be analyzing this a little bit more by employment status, but as we saw, a lot of people lost their jobs and probably lost health insurance because of that. And so I know other studies have shown that people who are worried about losing their jobs because they have side effects and they won't get time off for.
Sure, that makes sense. We might come back to this point, but there was also a question about whether the mental health issues that you highlighted, might they have existed before COVID? And I imagine you'll talk about the limitations of a cross-sectional survey for that kind of question.
Yes, yeah, thanks, Jessica. Yes, of course. That is always going to be an issue just in demonstrating causality or the timing of some of these things that we've found. Now, the mental health issues, as I mentioned, they're recent to us over the past 2 weeks, and we did ask about lifeline diagnoses. So we did see that 25% had noted that they'd been diagnosed with depression in the past, and I can't remember, it was over 25% with anxiety, but the timing for the PHQ-2 versus these diagnoses, we did not establish that, and it is a very important thing to think about. But regardless of that, it does show that there is a very high burden of potential depressive and anxiety disorders in this population.
Sure. And I think, perhaps on both points, maybe can you talk about plans for sharing the findings and study report with the city or the state, just to help inform policies on knowledge about, vaccines being free and access to healthcare. So just interested in what the plans are for dissemination, in particular to city and state officials.
Yes, absolutely. So the report is now posted online, and we did invite some people from the Department of Health to this session, but recognizing that people are very busy, it can be difficult to find time to attend a webinar. We do hope to host meetings with community advisory board effectively. So people from Department of Health, other government organizations who might be able to use these data to develop further policies. But we also want to make sure that these data are disseminated to the community. So these various community organizations, we're planning to share the report and hopefully host some question and answer sessions. And again, work with our Harlem and Bronx prevention centers in ensuring that this is disseminated to all those community organizations that both assisted in recruitment, but also might be able to use these data to better support the people that they work with.
Great. Let me ask you if you would sort of reflect on the sense of vulnerability to HIV and how that sense of vulnerability might have influenced knowledge and attitudes regarding COVID-19 for LEXICON participants. And then to just go one step further in thinking about that vulnerability to HIV, and think about some lessons that we've learned from HIV programs to address that vulnerability.
So, I mean, it was very interesting to find that the HIV epidemic had actually had a positive effect on this community in terms of understanding how important it is to access healthcare, to follow the various recommendations in terms of protecting yourself. But we saw that predominantly in those groups who have been most impacted by HIV. So men who have sex with men, transgender women. As I mentioned, we saw it with non-Hispanic Black participants as well. So, as I noted, I think within those groups, there really was a tremendous amount of activism about HIV, making sure that people had access to care, to medications. I think we're all so grateful to all the activists during the 80s and 90s who absolutely changed the current sort of paradigm on getting access to experimental drugs before the patent runs out. So things that have been critical and really driven by the community in terms of protecting themselves definitely still have this lingering effect. And, again, as I mentioned, we didn't find the same finding about people saying protecting the community, but it is there. And I think there is some, really a good sense of, sorry, I can't think of the word. I'm thinking of adhesion, but that's not the correct word, but a sense of being part of something and people helping themselves there. But there's definitely people who are being left behind. And that's why I sort of think about the bisexual population. But I think some of those networks that were built and some of those efforts about peers being the ones who deliver messaging. So people that people trust, who aren't, sort of distant bureaucrats telling them that they need to do these things, people from within communities who go in and can allay concerns and suspicions about the medical establishment and so on. I think that's how we build on this and other diseases as well. There's that peer-to-peer dissemination of information, I think, is really critical.
Right. I think that certainly there's a lot of interest in getting access to the slides, and I think we'll make sure to send around links to do that. I wanted to just ask, I guess, coming from the FIA side of things, what your thoughts are on how representative these 1,000 or so participants are of the LGBTQ community in New York City. Any reflections on that?
Well, yeah, so we're actively comparing our data to data from other sources to see where we might diverge. But I will say, with online surveys, you're already pre-selecting a group, those people who have access to the internet, who will be reached by your dissemination methods or recruitment methods, and who are savvy enough to see the QR code and scan it and speak the languages, although we did have 4 languages, obviously, that didn't reach enough of people within the Asian community and so on. So there's definitely going to be some kind of bias already towards people who are a little bit more, as I mentioned, internet savvy. But I will say that the fact that we had pretty high levels of people without college education and lower income people, that does, to me, allay some of those concerns about the representativeness. But that's always going to be an issue. Our recruitment wasn't a household-based survey like the FIA one, so that that you're adequately covering the city. But
sure.
Yeah.
Sure. Another question that's come in, have you explored or had any thoughts about exploring correlations between depression and anxiety disorders and use of masking and other non-pharmacologic interventions?
We haven't, but I think that's a really great idea. As I mentioned, there's so much that we can explore with this, but I think that the mental health impact really is something that's very, it's something very impactful. And so I think there's a number of things that we should look at in terms of both what might be some of the drivers of this mental health impact versus some of the things that it might be associated with in terms of people adopting mitigating behaviors.
Mm-hmm. Okay. And I think you touched on this a little bit during your presentation, but, maybe just be good to hear a little bit more from you about the challenges in recruiting from the Bronx. We do have some participants in the webinar who are not New Yorkers and who are very international. And I think just sort of explaining a little bit about, the differences between Staten Island and the Bronx and so on. These all have their own local context, right?
Yeah, absolutely. So sort of similarly to other online surveys, and I think looking at the Tegan and Sarah Foundation survey, a really excellent survey, but it was more than 80% white, cisgender, gay or lesbian participants. And that's what we really wanted to try and avoid by all these different methods of recruitment, especially with the Harlem and the Bronx prevention centers, and ensuring that we had a more diverse racial profile. But there are still groups who, even in terms of just accessing online surveys, but being regularly online, those people might be more difficult to find. And the Bronx is an area that tends to have, it's a very diverse population there. Also, it's a group of sort of lower income in a lot of areas. And often it's very, very hard to reach people in the Bronx. And it's part of the reason why we have the Bronx Prevention Center is people who engage with the community and try to ensure that people who aren't represented, not just in online surveys, but clinical trials, there's a real gap of people of color being included. And that is certainly in the Bronx, a group that we see a lot of. Also, we had the specific issues that we had with the Bronx and Staten Island. We're also using Grindr. So Grindr was incredibly successful, both in Brooklyn and Manhattan, relatively successful in Queens, but we didn't get much for the buck with Grindr in Bronx and Staten Island. And I am really interested in looking to see if this is something that we're seeing with other surveys. But whereas in Brooklyn and Manhattan and to some extent Queens, you have a ton of different events and venues that cater to the LGBTQ population, you don't have as many of those in the Bronx at all. And we found virtually none in Staten Island.
Yeah.
I will
Yeah.
note one
Yeah,
thing.
I understand.
Yeah, one thing that I'm very interested in is trying to look at doing these latent class analyses, because when I was looking at patterns of vaccination, those people who aren't vaccinated in Staten Island have a very different profile, both racially and other kind of sort of demographic factors than those people who aren't vaccinated in Manhattan or who aren't vaccinated in Brooklyn or so on. So that's an area of further exploration, trying to understand what factors are driving vaccine reluctance or hesitancy in different demographic groups.
Great. Well, I think just in the interest of wrapping up on time, I think we should close here. I think we have covered most of the questions that have come in. And I know that our communications team will be sending around an announcement to everyone on how to access a link to the slide deck, because there's been a few requests for the slides. So let me just close here, and thank you, Andrea, for such a wonderful and rich presentation of this topic. I think it's given us all a lot of food for thought.
Thank you, Jessica. And thanks everyone again for joining. And
sure.
The LEXICON team.
And I don't know, Fatima or anybody else, if you need to want to say anything just as at the very end here, or not.
I think we're great. Thanks, Jessica, and thanks everyone for joining today's session. And we'll send out an announcement for our upcoming webinar in February. Thank you again for joining, and stay safe, everyone.
Yes, absolutely. Thank you. Bye-bye.